Thank you very much. And thank you for the introduction. So today I just wanted to start by discussing some of the work we had done on the assessment of automated brain tumor segmentation tools. So essentially what we wanted to do is look at existing tools which use different types of machine learning techniques and see how well they perform in clinical practice. And the reason stemming behind this is that there's been tools developed for things like the breadth dataset, etc., but how does it compare in the adult and pediatric clinical dataset? So I just wanted to give a bit of a brief introduction to that. So in terms of the relevance for segmentation, so at one point I did kind of think like, how relevant is tumor segmentation in actually a clinical environment, and how would it be useful? And the main things I came up with are that it's one of the elements is around having automated measurements of tumor volume and also for radiotherapy planning. So often we can hear within a clinical report like the tumor has grown in size or not. If we actually have these automated tumor measurements which cover the whole volume, could we therefore improve our diagnosis of what's going on? And also it would definitely be helpful within radiotherapy planning in general. Then the other side is for the purpose of research studies, and particularly with large machine learning projects, which require large data sets that are segmented. It's very difficult and challenging to get radiologists to segment thousands of data sets. So having automated segmentation techniques could help in that aspect. And eventually, I do hope that with automated segmentation, we can start to integrate quantitative imaging into the clinic, because then we can start reporting actually quantitative values within tumor regions, etc., automatically. And that's with the idea that we can then start to improve in terms of grading and molecular characterization. So it's kind of like seeing a clinical relevance for this. So the aims for this project, and I'll say that this was a project conducted pre-COVID, so it's been about 2 years ago now. So the software that we've analyzed was the software which was existing 2 years ago. And it was part of a master project conducted by René Rassiember. So essentially, we took the breadth data set and we tried to do the segmentation with these three softwares, so OncoHabitats, Bratumia, and DeepMedic. And then we wanted to assess the software within the pediatric and adult cohort that I mentioned, and how does it compare to the manual segmentation performed by a radiologist. I'll mention the reasons why we focus on Bratumia alone when I'm describing the software in a bit. So essentially, these are the three data sets that we used. So first on the left is the breadth data set. So that was 66 patients. All data sets had a range of low and high grade gliomas. And the pediatric cohort had 27 patients, whereas the adult cohort had 13 patients. Two things to point out in terms of the differences. So in terms of the sequences acquired, most software require these four different imaging modalities. So a pre and post contrast T1, a T2 axial, and a FLAIR. In the case of the Imperial data set, we did not have a T2 axial. But what we did is we had a diffusion data set, and we just used the B0 of that data set as a replacement for the T2. And this is where you start seeing that there's a difference in clinical implementation versus what sometimes can be done in one of these challenges, such as the breadth challenge. The other thing to consider is that the way radiologists segmented the tumors was slightly different. So whereas in the adult cohort, we use the whole tumor, including edema. Within the pediatric cohort, the radiologists excluded edema. So that can have an effect on the results that I'll be showing as well. And what I mean in terms of segmentation is that with the breadth data set, you had these different regions segmented. So you had edema separately, tumor enhancement, necrosis. So you have these different elements. Whereas with the clinical data set, we just had one ROI. So what we were doing there is actually just combining the segmentations from the tools that are being provided to make that one ROI in the clinical data sets that we had. So introducing the software. So on the left is Bratumia. It's one of the main benefits of it in terms of ease of use is that it comes with a GUI, and it's pre-trained and relatively easy to run. It does require the four modalities that I mentioned, so the pre and post contrast T1 and the T2 axial and the flare. And it uses decision forest classifiers rather than CNNs, convolutional neural networks, which are used by the other two software. OncoHabitats is a online tool, or at least was an online tool at the time of the analysis, which meant that we had to upload the data online and then you get back your results. And one of the reasons, in fact, why we couldn't analyze the clinical data set on OncoHabitats was that we did not have the ethics to upload the data set. So essentially, we were unable to use the software for clinical purposes. The third software, which is DeepMedic, is also convolutional neural network-based software. We used Google Colab, so we had access to GPUs in that way. So it's command line based, so probably the least user-friendly of the three software. But as you'll see in the results, it was quite it did give quite good results. In terms of the clinical data sets, we hadn't got to the stage of running it DeepMedic on our data. And that was the next step. We did run into issues with how it was processing and accepting the data formats in terms of image size, etc. So the student was struggling a little bit on that level, and we decided to kind of pause that for the purposes of the master's project. So in terms of segmentation, what we're measuring is the dice score. So for those who are not as familiar with the segmentation, and measuring of the accuracy. So what you do is you have your ground truth segmentation, which is shown in green here, and then your automatic segmentation from the different software, which is shown in yellow here. Anything which is an overlap between the two is a true positive. Anything that is missing from the automatic segmentation but present in the actual ground truth segmentation is considered a false negative. And anything that is seen as tumor by the automatic segmentation but not by the ground truth is seen as a false positive. And then you measure this dice score. So the dice score is given as a value between 0 and 1, with 1 meaning that there's complete overlap. So there's 0 false positives and 0 false negatives. And as you obviously have more or less false positives and false negatives, you get a lower ratio. So this is the breadth comparison. So this is the breadth data set and a comparison of the three different software. So top row, you'll see a really good segmentation of this tumor. So there's a T2 axial on the left and then the three different software. And you've got quite a high dice score, which is what you'd expect here. Now, the thing I want to point out in the next row is that if you had to see the tumor, which is at the top part of the brain there, you'll notice that actually the segmentations of the three software was relatively good. And it was quite a strong overlap from our perspective. But in terms of the dice score, they are quite low. Now, the main issue here is that the way breadth works is that we didn't have the ground truth available to us. So we couldn't actually compare to what the ground truth is. So what we do is we segment the tumors, we upload them online, and then we get back information of the dice score within each of the patient's data sets that we uploaded. So while we have a low dice score, we do question what was the ground truth defined in this patient. And I think that is one of probably the biggest challenges of segmentation, automated segmentation, and developing tools that are clinical relevant, because we do need to make sure that what we're training our data on is the actual truth rather than one view of the truth by one person kind of thing. And I'll describe that again in a bit later in terms of the main challenges for it. The other thing I wanted to point out is that the time it takes for each case is slightly different for software. Bratumia was the GUI interface. It doesn't use CNNs, so we'd expect it to be a bit shorter in terms of processing time. OncoHabitats is online, so it took 30 minutes, and DeepMedic, we were using Google Colab, so with GPU access, and it was taking 10 minutes. I'd imagine it would take longer, but on a standard desktop, it's not something that we've tried. So in terms of dice score within the BREADS dataset, so this is the 66 patients, you can see that there's quite a range. Mostly they all work fairly well. OncoHabitats had a much wider range of dice scores. But again, as I was saying, some of the dice scores might be low, but are they really low, or is there an issue with ground truth, etc.? So there is that challenge. And essentially what we saw is that DeepMedic was the one which performed the best. So the average dice score was 0.89, whereas Bratumia and OncoHabitats were quite similar, with OncoHabitats having a much wider range of values. Again, in terms of computation time, Bratumia had the best computational time there, and OncoHabitats was the one which took the longest to process each image. So then the other thing is to start and look at the adult versus pediatric cohort. And the next thing you'll see is that the dice score were actually really good in the adult population, and there was a very big range within the pediatric population. Now, to some extent, this is not unsurprising, and that's because Bratumia was not trained on a pediatric cohort, so it's never saw any pediatric brain tumors. And we do know that there are differences between the adult and pediatric tumors. So this was really just, it's a bit of a check, like how well do existing software perform? Are we focusing solely on adults and therefore forgetting about different types of tumor that exists, etc. The other thing to note is that there was a range. So mostly the ones with the lower score were grade 4 tumors, but actually there were some grade 4 tumors which also had high dice score. So there was no correlation between tumor grades and how well the Bratumia in this case performed. And then in terms of showing some good examples, so these are two different tumors. The top row is an adult brain tumor, the bottom row is a pediatric brain tumor. You see the radiologist segmentation in yellow. You see Bratumia segmentation in red and the overlap on the right. And in this case, both of these patients showed a very good dice score. But I think there's a lot more to learn from looking at the ones which have issues in terms of what we're highlighting. And here I just want to, I'm essentially going to go into 4 different problems that we identified. So first goes back to the ground truth. So this is an adult tumor. And you'd see the segmentation in yellow and Bratumias in pink. So there's a bit of a, if you look at the red component on the right on the overlay, there's quite a big chunk which is being missed in terms of the radiologist segmentation compared to Bratumia. And this is where it becomes tricky in terms of who segmented the tumor and how they considered what is tumor and what is not, because there will be differences amongst different radiologists, and potentially having a automated segmentation to guide the radiologist could lead to a more repeatable measurements amongst radiologists as well. So that is something to keep in mind in terms of what we define as ground truth. The other thing, so the second item is a case where no tumor was detected whatsoever. And this is an example in a pediatric tumor. And again, this is a, so this is an example where the software was not trained with any of these tumors. It is quite a small, it's quite a small region, and therefore it wasn't detected. So again, this is referring back to the need for proper training data sets to cover different types of tumor. The third issue we had was around what I alluded to in the beginning, which is that some within the pediatric cohort, we did not include edema. In this case, Pratumia considered most of the tumor as edema rather than actual tumor. Again, this is a diffuse midline glioma, which the software was not trained to look at. So you do see a low DICE score, but actually if you had to include edema, then the DICE score would be quite high. But in our case, because the radiologist did not include DICE score in their segmentation, we didn't include that in our evaluation for the pediatric cohort. The fourth issue, again, this is another pediatric tumor, and this was more to do with the technicality of masking the brain. So what's done by most of this software is it requires or it processes automatically a brain mask. And what the software did was essentially remove half of the tumor from the image by masking it out. So you'll see this hole in blue in the segmentation there. And essentially what's happening is that we're putting so many technical processing steps to eliminate the information that we need. So it's kind of meaning we do really need to start looking at minimizing our processing steps and having quality control checks within the different processes that we do. And these are all points to be aware of when doing any form of automated segmentation on a clinical data set. So just to conclude in discussion, there's these different segmentation issues in terms of the tumor boundary discrepancy, not having the correct data to detect, and therefore not detecting the tumor, having the mask excludes tumor regions, and having this variation in how radiologists define what is tumor and what is not, particularly with relation to edema or not. And in terms of potential solutions, what we're suggesting is that for ground truth, we do need comparisons with multiple raters. It is not sufficient to have one radiologist's view, but we do need to have multiple views, particularly for training data sets. Then the other aspect is that we need to start including other tumor types rather than just focusing on glioblastoma or low-grade glioma in terms of brain tumors, and implementing those, particularly in a pediatric cohort, in terms of getting the right training step. The next thing is improving our technical processing in terms of things like brain masking, etc. And finally, when doing a comparison, we need to clearly define the criteria radiologists use. And that's a little bit tricky because within different clinical data sets, what is important will vary a little bit. And again, if you think about the applications which I referred to in the beginning, so things like criteria for looking at tumor size or radiotherapy regions that you'd like to segment, they're both very different things. So what a radiologist would define as a tumor area which is growing or decreasing might not include edema, whereas if you are doing radiotherapy, you might want to include regions which are appearing as not normal. So the application also has an effect on the registration itself. So it does make it into a much more complex problem. And with that, I'd like to thank all the people who've been involved in the study, in particular Renera Siember, who did the analysis for the study in her master's projects. She's currently doing a PhD. And also Patrick Hales, who's been leading on the pediatric cohort side of stuff. And if you have any questions,